Hello.
Yeah, I prefer to say hello because in Rwanda I may say good evening as we have got this opportunity. I'm Nakiretu Saimana. I'm the chairperson of TORG Education and Training Committee. I take this opportunity to welcome you all for attending the today's session. I welcome you all. I take this opportunity to welcome the new members. I welcome our founder, the president of TORG, Adebusora. You are very welcome. And also welcome the new member, Chanchim Bargarat. I don't know if I pronounce the name from India. Is a new member that we are with today. And hi, welcome. Very, very proud, very, very sympathetic. Welcome our speaker of today, Joe William Cody. You are very welcome. Briefly, the talk is founded by Adebusora in 2015. The purpose is to increase and sharing knowledge for the operating theater personnel. The member including nurses, surgeons, perfusionists, anaesthetists, and so on. So this is a good creativity. And among the talk we are huge, we have different quality department. We have educational training committee, we have research. Now today, we are with education and training committees. And during our training and education committees, we invite the people with experience, as we have the speaker of today, to share the knowledge and the skills so that we will increase our knowledge. Also, the patient will receive high quality care. The topic of today is aseptic techniques, the key to surgical techniques and patient safety. I'm no longer going to explain it well, but it is well understandable and it is a sensitive topic. When our patients are received, also the surgical team is also safe for their procedure and for the care the patient has received. So without delaying, I take this opportunity to highly welcome Joe William Cody for today's session. You are welcome.
Thank you so much. Thank you so much. Can everyone hear me?
Yes.
Yeah. Okay. Let me get everyone, first of all, to go into chat and put in there where you're from. I'm from Seattle, Washington of the United States. And I believe I put mine in there, but those who have just entered the chat may not have seen it. So I'm going to put it in there one more time so that I can let you all know where I'm from. Okay. Seattle, Washington, USA. Wow. Thank you so much. Thank you so much.
Excuse me, ma.
Yes.
Yes. I am Blessed Nobu. I want to read out your biography, please.
Okay.
Permit me to do that. Okay.
You got it. Go ahead. Go right ahead. Thank you.
Okay. Ladies and gentlemen, allow me to introduce Josephine Williams Cody, a remarkable individual who embarked on her journey as a surgical technologist back in 2004. From the outset, her deep-rooted passion for medicine led her to pursue a career in the medical field, setting the stage for an inspiring trajectory of professional growth and accomplishments. Josephine's path to becoming a certified surgical technologist began with the acquisition of her associate degree in surgical technology in 2005, a moment she described as both rewarding and challenging. This certification served as the foundation for her roles in the operating room, where she adaptively prepared instruments for surgery and prioritized patient safety during intricate procedures. Over the years, Josephine has honed her skills, faced numerous challenges, and embraced the demands of her profession. Long hours, high-stress situations, and the constant need to adapt to medical advancements were obstacles she courageously confronted. Yet, amidst these challenges, Josephine discovered great fulfillment in her role, finding joy in collaborating with patients and medical professionals to achieve successful outcomes. Fueled by her desire to share her knowledge and passion with future generations, Josephine transitions to become a surgical educator in 2012. As a teacher, she took immense pleasure in witnessing her students thrive and emerge as accomplished surgical professionals. This dedication and commitment led to her promotion as Program Director of Surgical Technology at the Pima Medical Institute in 2014. Undeterred in her pursuit of knowledge, Josephine attained her Bachelor's of Science in Surgical Technology in 2015, broadening her expertise and preparing herself to impart a diverse range of surgical procedures and techniques to her students. Ever forward-looking, Josephine continued her educational journey, culminating in obtaining her master's qualification in 2021. And with this advanced degree, she aspired to create innovative teaching methods and actively shape the future of surgical technology for generations to come. Josephine Williams' Cody's unwavering dedication to advancing the field of surgical technology has left an indelible impact. Through her selfless commitment to education, she has influenced countless aspiring surgical professionals, elevating the standard of patient care worldwide. As she continues to inspire others with her passion and unyielding dedication to education, Josephine remains a guiding light in the realm of surgical technology, leaving an enduring legacy that will shape the future of the profession. With her relentless pursuit of progress and improvement, Josephine Williams Cody, popularly known as Jo Williams Cody, is undeniably a beacon of excellence in the world of surgical technology. Join me to welcome Jo Williams to speak to us. Welcome, Jo. Thank you.
Thank you so much. Thank you so much. Thank you for having me. I'd like to thank you personally, the operating room, global, international. I thank you so much for allowing me to present today on aseptic technique and, of course, the safety of a patient or patients across the spectrum. Again, my name is Josephine Williams Cody, and it is a pleasure to be here.
Nice.
So let's start off first before I share my screen of aseptic technique. Aseptic technique starts from the beginning in the classroom of learning what it means, learning what to touch, what not to touch. So I have been teaching students across the United States of professionalism and how this begins. Well, when we say aseptic technique, we're saying, okay, here's the poop point. You can't touch anything past the poop point, right? But before I start with not being able to touch what is inside this, I have to explain why. Why is that? The human body has normal flora. What is normal flora? Normal flora is resident flora, right? We all live with resident flora. We also live with our other buddies, transient flora, right? So the transient flora is what is out here that lands here. They all get along together. That's these microbes that protect our bodies, okay? So the normal flora, which is your transient and your resident. Transient, we can wash off our hands. Hence, basic hand wash. We have to be able to understand why is it that we're pressured in the medical field to wash our hands constantly. That's to get rid of the transient flora. Can we really get rid of the resident flora? Absolutely not. So when we do our basic hand wash, when we as surgical technologists does a surgical scrub, it's getting rid of the resident flora on top, but they're still there in the epidermis. So we're actually keeping them at bay when we actually do our surgical scrub in the OR. Aseptic technique not only performance in the ER or the OR, right? Performing aseptically. It's also providing aseptic surroundings on body. Hence, your OR attire. It starts with coming into the locker room of the operating room, right? You go into the operating room of the where you go and don your OR attire. But before you can do that, you must do a basic hand wash. What's a basic hand wash? Well, it's happy birthday to me ×2. Right? That's absolutely correct. You keep doing that. Once you get through with your basic hand wash, now you can take off your street clothes, don your OR cap, then don your OR attire. That's your scrubs that are provided by the hospital. All of this is now clean. So we're leaving what we brought into the hospital inside of the locker room, donning new clothing that's provided by the hospital, that's free of any bacteria that you may have bought in from the outside of the hospital. Now that we've donned our OR attire, we're now moving to the OR suite. Inside the OR suite is where now we're going to start putting on our proper PPEs, personal protective equipment. Once we put on all of that, we're ready to cross the red line. So aseptic technique starts at the beginning, which is when you walk into the locker room from the hospital side. So there's steps to aseptic technique. You have to get there. So I have to, in layman terms, teach my students what this is all about. What does this thing do? Why is it that we have to do so many basic hand washes? Well, we've got to get ready because we're entering an area where it's all about the what? Ager primo, patient first. So let's get into aseptic technique in surgery and the procedures. I'm going to go ahead and share my screen. I want to say welcome to everyone that's already been here in the room and those who just got here in the room. So I'm going to share my screen right quick. 1 second. There we go. Did everybody see that?
Yes, we can.
All right. Thank you so much. Okay, 1 second. All right. So understanding the importance and methods behind aseptic technique is key to a successful surgery. So right now, we're going to talk about the world of hygiene. Hygiene is so important. So when I say hygiene, I'm talking about you, making sure that you do your basic hand wash, making sure that you put deodorant on, make sure that you are clean when you come into the operating room. And this is so important because you don't want anything that could possibly flake off you into the patient. Now, yes, you don your OR attire, you have your proper PPEs on, but you're not scrubbed in yet. So you have to do everything aseptically. You have to be really, really careful in what you're doing in the operating room. Next slide. What is aseptic technique? I'm so glad you asked. It is a set of practices and procedures used to keep surgical environments free from infectious microorganisms. Let me go a little deeper with that. In the operating room, what we have to do is, as a staff member that work in the OR suite, we have to make sure that the OR room is prepared and ready for that patient. We damp dust in the operating room for the first procedure. Okay, don our non-sterile gloves, wipe down from top to bottom. We're arranging our furniture for that procedure, but at the same time, getting rid of all of the possible bacteria or dust or even dander that has settled on the furniture and the equipment. And that's these vectors and fomites, the insects that bite you. They're the ones that carry the bacteria or viruses, the fungi, the protozoas. So we have to make sure that the OR is clean. Guess what else? We have to make sure that the temperature is there. It's going to always be cold in the operating room, always, to keep the microbes down, because they cannot grow in cold. Some can, others, most can't. Okay, so it's the first line of defense, aseptic technique. It's so important in preventing SSIs, surgical site infections, okay, and HAIs. HAIs is a hospital-acquired infection. You come in with one thing, you leave out with another, right? Nosocomial infections, yes. So we want to ensure patient safety, that we do not transport anything to the patient. So when they leave out, they're free of contaminants, of SSI. Hence, that's why we blue the field. When the surgical technologist goes into the hospital or the OR and wipe down from top to bottom, we're doffing our gloves, glove to glove, skin to skin. That is an aseptic technique move. We're going to drop those gloves like it's poop. Okay? That's how we treat the operating room suite. Everywhere we go, we are surgically conscious of what's going on, and we anticipate what's coming next so we can beat it at its path. How is aseptic technique maintained? Well, I'm glad you asked. It's by creating that sterile field, using sterile equipment and supplies, and avoiding contamination from non-sterile items. Now, when we go into the OR to start to set up, we're actually putting a back table pack here, right? You see all this swinging? I can't have that swinging. So I have to tuck this, right? I'm not scrubbed in yet. So I have to treat everything aseptically and like it's poop. So every area in the OR that I open has a poop point, right? So I can easily open it up. And now I'm ready. Now, in the OR as a student or as a tech, you make sure everything is tucked. That way, nothing can fly onto the field. Because if that happens, that's contamination. Okay, so we teach all of this. We teach best practices of how best to go into the OR. It's steps to everything. Now, once we're ready and we've already opened up, we're going to go do a intense surgical scrub. There are impregnated brushes that are at the surgical sink that we have to do this 5 minutes or less. We try to do it in 3.5. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. We do all 5 fingers. Then we do the palm. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Now we're going to do a third of the arms. 1, 2, 3. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Do that third, this third, 2 inches above the elbow. Okay? And I told you steps to aseptic technique. It's got to be in front of you, not this high, not this low. And when it's time to actually scrub in and actually go into the OR, we're going to back into the OR like so. Push back and go in. And guess what? We're going to grab that towel by the poop point. See that poop point? That's what we touch. Aseptically. One. Then we dry. We can't go back. If we go back, it's contamination. We go up under here. This hand is wet. Dry those fingers. And drop it like it's what? Poop. Okay? So now we're ready to don our gown. Again, it's steps to everything in the operating room, aseptically. Again, it does not start at the field when we're draping. It starts all the way to that locker, from the locker room, all the way into the OR, to removing the drapes from off the field, to rolling it up, to put it in the bioburden container, which is red. So everything in the OR, we must know, because we have to know where you put all the bioburden drapes, your gown. We have to know how to doff our gowns, our gloves, once they are contaminated. We have to be careful that we do not interfere with the patient as far as any type of contaminants once we have finished with the procedure. It is so important, everybody, that we understand that aseptic technique is without contaminating, is pertaining to not contaminating whatever we're dealing with in the OR. Now, if we contaminate, we have to back out, go back out into the washroom, re-scrub, come back in. If somebody said that you, Blessing, contaminated, you can't sit there and say, no, I didn't. I don't remember me touching anything. No, Blessing, you have to own up to it, right, Beth? You have to own up to it that okay, I didn't see it, but I'm gonna go ahead and go there. There's no gray line in the operating room. Aseptic technique is what we're going for. And guess what? Everybody is watching you. Although we have our own job to do in the operating room, the anesthesiologist is watching you. The circulating nurse is watching you. Your co-worker is watching you. If they are with you scrubbed in, the surgeon is watching you in their peripheral. Everybody's got their eye on you for the betterment of the patient. I'm so adamant about making sure that teaching starts in the classroom, that students are aware that this is what we do. This is no game. You don't come to the operating room because, oh, this is nothing, I'm just coming for the pay. No, you come for the professionalism and to be able to agar primo, know that the patient is first, and you have these aseptic techniques. You're here with best practices that you got from school and that the hospital want to continue to enforce. And if you don't enforce them, guess what? You're going to get caught. And guess who's going to catch you? The hospital police. Here in the United States is JCO. They're going to get you. And guess what? They're going to fine you. Your hospital going to have to pay some money. And but guess what? Now we got to go do a continuing educational class so we can tell you how to do what you did wrong, that you should have known what to do from the beginning. Because you know what? Everybody goes to school, but some people like to lack, or should I say slack. They like to slack off in the operating room. I see it. When residents come in, I can tell from the beginning that they're babies. Oh, we got to watch those residents because residents come in, they're nervous, and we got to make sure that they are aseptically sound and they understand that they can't touch this. You can't do that. Oh, you need to back up over here because this is blue. When you have a new student, a lot of people don't want students to drape at first because they'll contaminate. They forget how to drape feet first, and anesthesiologist next for him to grab the drape. These things are sterile at this moment, and we need to make sure that we don't stop the procedure because you contaminate it. Doctor's going to be mad because they can't go play golf on time. They need to make sure that everybody's on point. They want a sound surgical technologist. They want a sound OR team. So here's some common methods for maintaining hand hygiene: the use of proper hand washing techniques and the application of antimicrobial solutions. They have that. They have them in different strengths at the same 2%, 4%. They even have the soap where it's not impregnated and that's a little lighter and you can hit the pump. They also have the ones that's Avogar or Sterilium. That's the best sterile or sterilant for scrubbing between the water and waterless. That's the best one. It's alcohol based, and you just go ahead and put the alcohol base Sterilium or Avogar on your hand or your both and go into the OR. By the time you get in the OR, you should be dry. And that has been proven that the alcohol base is better than the water. Okay, so gowning and gloving, the wearing of personal protective equipment to reduce the spread of contaminants. Putting on that gown is not easy. I've taught my students, they have checkoffs to better and best don those gowns, but it takes practice. It takes practice to do an open glove technique, a closed glove technique, donning a second pair of gloves on the table, opening up a basic pack, opening up a envelope wrap. You have to be able to know how to aseptically open an envelope wrap and toss it. Everything, ladies and gentlemen, in the operating room has steps to it. You can't skip those. If you skip those steps, something's not going to go right. You have sterilization. That is an integral part of the OR. It's a cycle of where our instruments go after they leave the OR to sterile processing. They process this beginning in decontam to the washer. On the other side of the room is the clean room for the instruments. You assemble them at the same time. You're watching to make sure that there's no bioburden inside of the crevices of your instruments. Everybody makes sure in sterile processing that all the instruments are working and we're all golden. Now we can assemble. In sterile processing, again, there's steps to it. You're going to go ahead and put everything in order. You're going to put your biological indicator, your chemical indicator where it belongs in each instrument set. Now you're going to cover it up, wrap it, put it into the autoclave, the sterilant, or the Sterad, whatever you need to do, slide it in there, get it sterilized. Now it's event related. Okay, so now when we get ready to set up our case cart for the next day, we go over there and get what sterile processing processed, make sure we check the date, who did it, what's in it, make sure that we check the integrity of each package. Oh, it's lovely. This is a nice position. Because you know what? We know what we're supposed to do, and we practice this all the time. If you know your job, nobody will ever have to watch you because they trust you. That's why they hired you. So we're checking the integrity of the package. Now we're putting it with the other packages to be opened in the case cart for the next day procedure. So that's how we do from sterile processing. That's the process of eliminating all microorganisms and their spores through the use of chemical and physical methods. Decontam, they take the brush and they go in between the crevices. Then they have a machine they put with bubbles that they put the instruments in, a cavitation, and it shakes like this here to make sure that all the bioburden is gone from underneath the crevices. So then when it goes over to the clean side, after it's gone through the washer, then we're there to double check. And then we're there, or sterile processing employees is there to make sure it is in working order. When I get it on the back table, I make sure that before I put that instrument case on my back table, I make sure that I've checked the integrity, make sure it's gone through the process, open up the container, put it up, out, open up the filter, put it up in the air, make sure it's gone through the process, no perforations, no strike through, put that under there. Now, when it's time for me, after I've scrubbed in, I'll go and get the instrument case. Guess what? You don't just pull it out. You aseptically pull it out like it's what? Poop. Back up. Circulator, can you check the filter? She'll check the filter. She'll put it up in the air like I did the top, but she'll do the bottom. If it's in there, she'll check it. Now I can put it on my back table. Aseptically. When you are doing surgery, everything depends on how you move. Ladies and gentlemen, when you in the operating room, you could be Miss Prissy, Mr. Prissy. You can touch things like so, because that's how you handle things aseptically. Let's go to the next slide. So here are the consequences of you not doing it the right way. Wound infections, okay? That's at the site of surgery that can cause patient discomfort and prolong recovery time. Then you have extended hospital stay. Infections and complications will keep you in the hospital a little bit longer. Then the complications, failure to maintain aseptic technique during surgery can result in unexpected complications. That's why we watch everybody. But once we get to work with a surgical team, you know that they know that we all watching each other, but we're not there to like be a supervisor for them. I'm not there to watch you and tell you, okay, remember to do this. Nobody tells us to do our job, how to do our job, because we come in knowing how to do the job in a collaborative effort as a team. Granted, sometimes he likes to hold his mask at half staff. So before you open up, you'll have to say, Dr. Thomas, I'm opening up. Can you pull your mask up? Oh, sure. So those are little things that you have to watch when you're in the operating room. Here's some challenges for you. Time constraint. Now, in every hospital, you have maybe 4 or 5 surgeries in your room. You have a laparoscopic cholecystectomy. You may have an open belly. You may even have a laparoscopic, hysterectomy. You may have those type of procedures, but guess what? There's a time in between. Hospitals have an agenda to make sure that everything that we do goes in order. Okay, so you've got time constraints. Effective aseptic technique can require more time and effort, right? So if you know your job, that means it's 6:30 a.m. You cut at 7:15. That tells me I have to be conscious of the time. I have to make sure that I'm in there and ready to get ready to do this procedure. Go to the field, set up, do the procedure with the surgeon. Turnover. We have 5 minutes to turn over. That's the challenge. Okay, effective aseptic technique can require more time and effort, but can lead to pressure to shortcut procedures. And I can't have that. I don't want that in the operating room. Surgeon definitely don't want that. And I don't want them looking at me because I was too slow in setting up. If you have to be waited on in the OR, then they're going to pull you aside so that they can get somebody in there so that we can go ahead and turn around, because we have patients waiting. And of course, the doctor got to go play golf. Okay. Staff training. Many healthcare workers require ongoing training in order to follow best practices and stay up to date. Now, for us, we have this AST book. Okay, it's a journal, Association for Surgical Technologists. We stay up to date with it. Say I did plastics for 7 years and I'm still doing plastics, but I'm a member of AST. Well, in that book, they also have procedures to keep up with my continuing educations. Well, they have these units that we read up on what's going on outside of plastics. Say it's something that's laparoscopic or a new way that Da Vinci has performed a new type of procedure with the doctor in England, and we're in the US with the patient. They may have new procedures that I don't know about, just in case I want to go back into the big house, which is the big hospital outside of plastics. I want to do general. Continuing educational units and training, making sure we stay aseptic is paramount. You've got equipment and supplies, challenges there. Access to sterile processing or sterile equipment and supplies can be difficult, costly in some settings. So it's always good to make sure that everything is all set. Everything is there, all instruments are there. And these are challenges. Not every hospital facility has everything. So that particular patient may be transferred to another facility so that they can best be cared for. Here's some best practices for training and monitoring adherence to aseptic technique. Initial training. Training should be comprehensive, hands-on, with follow-up assessments to ensure every staff member is competent, because we do get lax. We are there for 8. I've been here 18 years. Nobody can tell me what to do. Oh yeah, you need to go open up a current book, because right now you tend to slack off on your techniques. On the table, we keep our hands above. Aseptically as a tech, and anyone that's in the OR team that's scrubbed in. So it's the scrub tech and the doctor, his residents that are scrubbed in, and the PAs. Everybody must keep their hands from here to their above the waist, right here. Okay, so we all are like this. You know you're not supposed to have your hands up underneath the axillary. Why? Because it's contamination. But we do see it. People get lax when they shouldn't, but I do see it. I'm sorry if I called you out, but that is not best practices, and that's not aseptic technique. Also, ongoing education, continual education and training is very important to keep staff up to date on current evidence-based practices. That happens in services. Everybody goes to it. Oh, here's what we got. We just bought a new instrument in. We all using this. This is how it should be used. Oh, here's the new needle driver, the laparoscopic needle driver. And this is how we do it inside the insufflated belly. And this is how we do it. And you'll put it on here and load it there, pass it to the surgeon aseptically. Again, there's steps to everything, okay? Quality control, routine evaluations, audits can help identify areas where the team needs to focus and improve adherence. Because if you don't, the hospital police will come in and you'll get dinged for it because you forgot to put local, you forgot to put irrigation, not local, irrigation on your field, although you may not need it. But it's a part of being on your field just in case you have a fire. Nobody ever think, oh, we're not going to have it. This procedure is only 15 minutes. You should still have your irrigation on the field. That's a part of you being a surgical technologist and being a part of practicing best practice on your back table. Quality control. When they come in and do that QA, your JCO or the hospital police, they're looking for things that's supposed to happen. And if they don't, you gonna get them X and you gonna have to cough up some money. Now you're gonna get called in the office, and then now everybody's gonna have to get retrained. You can't skip over this stuff. You're gonna start having a high number of SSIs if you don't practice. That temperature's got to be low. For PDs, it's up a little bit higher, but you've got to be able to understand that inside that OR, that pressure in the OR is what? Positive. It's positive air pressure, airflow, because on the outside of the OR, you don't want that type of oxygen or air flying in the OR. Instead, you want positive pressure. So when somebody opens up the OR door and the air flows out. Yes. Oh, okay. Thought he raised his hand. Okay. So last but not least, everybody, the critical role of aseptic technique in surgical outcomes. It's effective aseptic technique, surgical conscious anticipation to prevent patient infections, decreasing the risks of complications, improving overall surgical outcomes. Healthcare workers should prioritize the practice in their everyday routines to ensure that they are providing the highest standard of patient care. Thank you, everybody, for having me.
Thank you so much. Let's see.
Thank you all.
May I have one question, please?
Thank you so much. I think it's been a beautiful presentation. We've learned a lot, a lot. I think one of the team members is coordinating the questions and answers. I think he's here. Let me see.
Thank you so much, ma'am. It's really a wonderful presentation. Though I'm late before I join. Thank you very much.
You're so welcome. Habiba?
Yeah, it's me.
You're so welcome.
Thank you, ma'am.
Okay. Does anyone have any questions? If you have any
I got one question, please.
Let me see.
Why I knew you were going to ask a question.
Yeah. Okay, Godwin, you can unmute yourself and ask your question, I think.
What is the
Good
role of
evening to you
aerosol?
all, and thank you for the opportunity. Please, I want to find out, in our part of the world here, is really getting people to comply to some of these aseptic techniques. Yes, so I would be glad if you could share, if there's any recent study you could share, and then possibly something we could just use as a basis to convince others that this is actually the standard to be done, especially when it comes to changing outdoor clothing before entering the OR, and then with regards to ensuring that all indicators confirm sterility before surgical instruments are used. If there are studies around those areas and you could.
Thank you for that. When you're speaking on this, it's education. So the hospital have standards. Of course, my position and the curriculum and the requirements of being in this position to get certified as a surgical technologist, to become registered as a registered nurse. It's all a part of the curriculum, and it's the requirement. And so these are all put together in this, for me, for best practice in the 7th edition core curriculum that is provided by us.
Yeah.
These are set. These are best practices that are set by different organizations, but they all come together to mean the same thing, and that's for the betterment of the patient. These are tried, and if you think about it, you're bringing, and you have to be able to explain this to those who can't see this, maybe in layman terms. But if you think about it, anybody that's coming in from the outside, you're bringing in all types of contaminants or bacteria inside of the OR. So before you get into OR, it's almost like dousing yourself with clean everything. And that way you being not as pure, because of course we've got our buddies, the resident flora. So we have to do that surgical scrub to keep them at bay. But you got to be able to have the knowledge to know that bacteria lives on you. That's no question about it. There's resident transient flora that flies everywhere, that lands on you. Now, you could have, this is all good bacteria until it gets to where it's not supposed to be, such as E. coli.
Yeah.
It's not going to bother anyone as long as it stays in that intestines, right?
Yeah.
But once it gets out of it, then Houston, we have a problem. It's the same thing. You don't want to be liable for anyone with a surgical site infection because you came in with, and then you didn't notice that you had a tear. If you get a tear in one of your personal protective equipment, such as your gown or your sterile gloves, then you could possibly infect a person with whatever you have on you that you may not know. So best practices is taught prior to coming into that operating room. Nobody should be there without having some type of education and knowledge of aseptic technique and where it comes from, where it starts.
Thank you so much. That was brilliant. I'm going to call Clytie Davenport. Is it? You can unmute your
Hi,
microphone.
Clytie.
Yeah, that's Clytie. Thank you for saying it correct.
Hi.
I graduated 30 years ago. And as a surgical technologist, everyone knows we know what we're doing. And you're going to get the residents and some attending physicians that will come to you to teach them how to scrub and gown. But in school, as one of our extra credit books, we had the Alexander's book. And that's what I always have nurses look at. Mine's is
right
black.
here?
Yes,
Yeah.
that's the Bible of the OR.
That's the
That
Bible.
is the Bible.
Yep.
That's what I tell everybody.
And this is the 17th edition, so we've come a long way.
Yes, 1990s when I graduated. So with that being said, along with that book and what we are taught in our class, because we have to have classes before we get to the OR.
Yeah.
That's right.
To practice how to gown and glove and open.
Mm-hmm.
And so that's how, if you get that book, and you don't really have to beat yourself trying to get people to listen to you. Just show a chapter in that book.
Mm-hmm.
And then you go to the educator. But then some educators don't know either.
Mhm.
With that, so
Woo,
always
goodness,
have
it's hard.
that book. Then that
Yeah.
way, your headaches, oh my goodness, you would not believe. And even with so-called nurses that know how to scrub, they want to hurry up and tell you to go scrub, go scrub. I said,
Mhm.
I'm gonna open what I need to open, and then you can finish the rest.
Yeah.
Put it in the basin. Most places, because I'm from Michigan, I'm used to a double ring stand.
Mhm.
But I've worked in Dayton, Ohio. People are getting away from using double ring stands to open supplies. Everybody wants to throw it on the back table,
Mhm.
which I hate. But see, it's all in how you present yourself too. But with that book, you can have it in the operating room and just have people look at it, or you can tell the residents, like I do, especially with GYN doctors that come in from labor and delivery and think it's going to be the same show. No,
No. Yeah.
no. It's like, let me get with you after the class, after the case, and we're going to do it the correct way, even though it's cutting into my time, turnover time, because we do have doctors do come and look and see how fast you're turning over the room.
Mhm. Mhm.
So just that book will be helpful.
Mhm.
Yeah.
You're
Thanks.
absolutely right. And then we have a pocket guide. The pocket guide also
Oh,
is your
really?
best. Oh, yes. I have everything in here, everybody. So I have, this here has every procedure there is in it.
Yeah, that's like the Alexanders. I've never seen
And
that.
then-
I didn't have
and
that. I'm
then-
old.
Then your surgical notes.
I didn't have
So-
that either.
You can't go wrong with some of these best practices here.
Right. Right.
So if you do anything wrong, you're choosing to do it, you cannot be trusted.
Yeah.
That is the integrity
Yes.
that I wouldn't want that if I'm going to have surgery. I need to make sure who is the tech. Are they certified? I need to make sure we've got somebody good that's operating on me. I don't want to cut corners.
Yeah.
Correct.
Yeah.
Correct.
That's correct. Thank you so much. That was a brilliant recommendation from Clyde.
Thank you.
Thank you for saying that. I'm going to call Barry. You can introduce yourself and your country and then ask your question if that's okay. Barry?
Hello, everyone.
Yeah.
Hi.
Can you?
Bari Kariwaja. You may
Can you-
unmute us
Kawaja
again.
from United Arab Emirates.
Okay, you can ask your question if that's okay.
Thank you so much, ma'am, for your such a brilliant effort. And I especially thank to the operating room global team for such a great initiative to educate the people around the globe.
Yeah.
And I actually learned a lot from your this presentation, and I would like to add certain points. Like we talk about the operating room temperature and the pressure, that these two factors add to the aseptic environment. But there are, I think, certain other things that, like your operating room lighting system, if you have adequate lighting system and illumination of the operating room, you must focus on the lighting before scrubbing or before starting the procedure. It will help you to maintain the integrity of the aseptic technique or the procedure. And second thing is the like when we start the procedure, where should certain things actually be, like where should be your back table, where should be the anesthesia machine, where should be the your diathermy machine, and like all other equipment. So it will help us to maintain the aseptic field and entire procedure in our entire time. I thank you so much, ma'am, for having me, and I thanks the operating room global for taking such initiative. Thank you so much.
Thank you, Barry. We appreciate that. And you're right that the temperature, the positive pressure in the OR with the flow of it, making sure you have those right filters in there to help to lower the bacteria count is all so important. And again, it's for the betterment of the patient, and it's patient first. It's never about anyone in the OR but the patient. Agro primo, right, Clytie?
Thank you, ma'am.
Thank you so much. That was brilliant. Thank you, Joe. Thanks for the audience. I think we have more questions coming up. I could see, let me see. Oluwatoyin, you can unmute your microphone and introduce yourself and your country. Thank you. Oluwatoyin.
Hi, everyone. Hi,
Yes,
everyone.
hi.
Thank you so much, TORG team, and thank you so much, Josephine, for delivering such a beautiful presentation. My name is Oluwatoyin, and I'm from United States, Colorado, precisely. I have been in the OR for quite some time, 10 years going now, and thank God you mentioned it. I think it should be a teamwork. It shouldn't be, it should never be about you thinking someone is trying to throw you under the bus or someone is trying to make you feel like you're not competent. When someone says, I've been doing this for 10 years and I precepted a younger colleague of mine, and I was trying to pass Foley, and she told me, oh, you contaminated. I didn't see anything. I just said, get me another gloves. Despite the fact that I was a preceptor, I just told her, get me another gloves, took it out, and it shouldn't be about you thinking, I've been doing this for long, why should you challenge me? No, it should be about the patient, because if anything happens on the long run to that patient, and someone told you you contaminated, for example, and you argued it, then they're gonna call you to come and say you're part of whatever happens, because she told me. And after everything, I had to commend that thank you for speaking up. That is one attribute that every surgical person must possess. You must be able to speak up, even if it's to the surgeon. Speak up. Let the surgeon know. Oh, there was a time too we were having a surgery, and what I have known in my practice is after 1 hour, 1.5 hours of surgery, I expect you to all change your gloves. I mean, the surgeon now, the surgical tech. So I was telling this particular surgeon that was new, after 1.5 hours of surgery, it's a general surgery, and I brought out another glove, and I was like, team, it's time to change your gloves. And he was like, what do you mean change your gloves? I said, you've been working for 1.5 hours, and that's a standard procedure for everybody to change gloves. Now you buy a burden on those gloves is high, and I was just trying to explain, and he was trying to make me feel like, why would you tell me that? I didn't say much. I just said, okay, I just texted my manager. And she came inside. Sir, it's time to change your gloves. So when he saw that everybody meant business, he took out his glove and changed it. After the procedure, I had to go meet him and show him the reason I was saying what I was saying, not that I wanted to throw you under the bus or try to make you feel like you don't know what you're doing. It's just I want a patient to be safe, and at the same time, I want you to be able to keep your license. If anything happens today, your license is going, and I don't want to go with you. So you have to make sure that everything we do in the OR, we have to know that it has reasons, and the reasons must be followed. It has protocols. Every protocol must be followed. Although there might be protocols in your workplace, but there are general protocols that apply to everybody that I think is something that we should apply, and that will make our work and aseptic technique better. Also, I want to add that it is important that before we start, during the day, in the day, we wipe down our OR. It helps reduces the chances of infection. I mean, when you get to the OR, before you open anything at all, try to wipe that. In my own place that I work presently, we use a wipe called Cavi, and we just wipe down the bed, the surfaces, just to reduce the load of infection before we bring anything in and open.
Yes, we mentioned that. I mentioned that at the beginning, how prior to going into the OR, you damp your damp dust the OR prior to, especially the first case. And after that, you have your turnover team that does the rest. But definitely because you don't know what is settled on your furniture with your vectors. You got your fomites that may have flown in and settled things down. So yes, definitely. You spoke about that earlier. You may have come in afterwards.
Yes, I think so. Thank you so much. That's just my contribution.
Welcome.
Thank you, Josephine.
You're welcome.
Thank you. Thank you for saying that. That was a brilliant contribution. I think Hawa, I was saying her hands. Hawa, I'm not sure if I'm pronouncing that correctly now. So you can unmute your microphone and ask your question. Hawa, I think I saw that name. Just okay.
Thank you very
Maybe
much
she's
for the
gone.
time given to me.
Think like
I'm Hawa Mustafa.
Okay.
Hi.
Are you with me? Hello?
Hello.
Yeah, we can hear you.
Yes, I'm Hawa Mustafa Daraka, calling from Nigeria, Zaria, Kaduna State.
Okay.
It's nice being with you. I'm just a new colleague entering the system, now still a student yet to become a registered one. So please, we need more enlightenment and encouragement about OR. Thank you for everything.
Thank you so much. Thank you, Hawa.
What did she ask her question?
The normal
just...
temperature and humidity in the operating theater and more encouragement about OR, please.
Did I get that correctly? I think she wants to know the normal temperature and humidity in the operating room environment, right? I think so.
Yes.
So the temperature, it should vary, though we keep it down to 68, somewhere around 68. It could be different in other hospitals. It's according to the age of the patient. And then also if it's a PD, the temperature is a little bit higher, but also you're dealing with the humidity as well. But I believe we keep it down to like a 67, 68 in the OR. I think that's about about that. They fluctuate, but it doesn't get any warmer than that, or unless we have a PD to come in, we raise the temperature higher.
Yeah, thank you so much. I think Clytie wants to say something.
Yes, I want to piggyback on the lady from Ghana about changing their gloves, or Colorado.
Mm-hmm.
That's between the nurse and the scrub. We communicate before, during, and after the case. If I ask the nurse, or I give her the eye contact, because that's how I was taught, to we, like hand signals, so she doesn't have to really talk to the doctor. I'll do it, and then she'll start, and then I would say, it's about time for us to all change our gloves, but first I'll do it myself. And then some doctors just look at me like, I say, yeah, we've been doing it, we've been in here for a while. And then some doctors like, okay, and just take their gloves off. And then
because you know what, that lessens the time. That's the other thing with time. You can't prolong time of asking questions back and forth. If he trusts in you, Clytie, then he's going to go ahead and do what you said, and he's going to honor that.
Yes, and it's a rapport you have with the doctors you work with all the time too.
Thank you so much. Yeah, exactly. I think Manasseh wants to say something. Manasseh, and you can introduce yourself and mention your country as well.
Yes, I'm here. I'm Manasseh from Rwanda.
Yep, you can ask your question. Thank you.
It's just an input, it's not a question.
Okay, that's fine.
First of all, I appreciate this presentation. It was very good.
Yeah.
I think, Josephine, thank you, and may God bless you.
Amen.
Thank you so much. I appreciate that. Thank you.
Yes, my input is that most of the time we do things like routine. We are not even just considering evidence-based practice, which is very current.
Yeah.
So my input is that maybe for the next session, we can just look the way we can even search for the relevant up-to-date information. So because sometimes we, as one of my colleagues has mentioned, we copy-paste. We do things because maybe we're working with people whom they can say, me, I spend like 20 years doing the same. So you're coming from school right away. How can you convince me? How can you? So sometimes we met with such kind of challenges. So my input is that maybe we need just to look how can search the up-to-date one, the current, so that we can work as we are doing things in standard for this aseptic. Another thing is about books. The books you have just shown us. Some of us maybe depending on the country we are in, we can't have access to that book. Is there an ebook of that books you have showed us, so that we can just share with us, and then we can read it through, so that we can be updated. Thank you.
Yes,
Thank you,
I can do that. There are some that you can share that are PDF, but some of the others that are owned by the publishers of Cengage or Elsevier, we only have access to view it, but we can't download it. But there are some that I do have in a PDF form that I can share, that I can give to the host or co-host, and then she can give to you. So yes, thank you so much. I do understand that. And also to piggyback off of what you just said, I've seen my students go into the OR who have preceptors who want to teach them their way that's not aseptic. Now, the reason why we try to stay with the book that is encouraged is because these are students who have to take a certification.
Yeah.
That is what is being taught in the OR, is not on the test.
Yeah.
The aseptic way, the surgical conscious way, the ethical way is on the certification. And if they want to pass that test, they're going to have to stick with the book and not follow. So I do tell the students, you're going to see this, but now you'll see text, you'll see them pull the table from underneath instead of keeping their hands on top. Doesn't that kill you? Oh, that kills me. That is so wrong. They've contaminated from the second they put their hands up underneath the table. Okay, I'm sorry. That just drives me want to just.
Thank you.
But I'm okay. You're welcome.
Thank you so much. Thank you so much, everyone. I think time is far spent. If you still have any questions after this session, you can always send it across and we can pass it on to the speaker, and then she can get back and send it as a message. So like I mentioned, this session is recorded and it's going to be published tonight across TORG platforms, and everyone can get to see and go through over again. And I just want to use this opportunity to say thank you so much, Josephine, for honoring our invitation. I know it was so soon and so short.
You're so welcome.
Thank you so much. I know it's 10 a.m. at your end, or probably 11 by now. Thank you so much for that. It was very informative. I could see a lot of positive feedbacks in the chat session. And yeah, people are really saying it's worth it. So thank you so much. And definitely we're bringing you back soon.
Oh, you're so welcome. And what I just did is I put a link inside of chat just now for everyone to click on that. And those are my surgical technology students who practice at home, best practices, aseptic technique. Click on that, and they're going through the steps and the skills of the program, and you can keep up with them, see what they do, and practice along with them. So that is that. It's on YouTube.
Okay, thank you so much for doing that.
You're so welcome. It was a pleasure, everybody.
So basically, we've learned a lot tonight. Very informative session. And you mentioned a statement, which I actually wrote down personally. Everything in the OR has steps to it. So you can't skip any of those steps, or something is definitely not going to go right. So it happens every time. Sometimes you have all these medical students coming in, you have new students coming in, and because everyone gets to put on the same color of scrubs, especially in my facility, you don't really know who is who. And then a lot of people get contaminated. You get to re-scrub over and over again. Time factor is not on our side as well. One of the challenges, like you mentioned, time constraints, and then staff training and retraining needs to be done. Some people have this school of thought from a different environment saying they want to scrub for 5 minutes, maybe first case of the day, second scrub of the day, they will also want to scrub for 5 minutes. Sometimes you see surgeons coming in, they don't even have 5 minutes at all. Either it's first case or second case. So a lot of things go on in the operating room environment. Like you mentioned, there's resident flora, there's transient flora. It needs to start right from the locker room. You don't get to take it inside the OR environment. So thank you so much. It's been very informative. And like you mentioned, it's all about being surgically conscious. Like, you need to have this conscience. What if it's me that is going to be on that table? What if it's my family members? Am I going to allow that same thing to be done to them as well? So I think we're going to build up on this foundation that you've laid. We're going to go back to our respective institutions and improve our practices, because that's one of our goals with TORG. I must say thank you so much for facilitating that, for speaking tonight. It's been a privilege to listen to you, especially as the program director of Pima, surgical technology. And we might have maybe Africans that want to transition into surgical technology. If you don't mind, we can get a day and arrange a session that says how to become a surgical technology technologist
no
in
problem.
the US from scratch.
Yes.
Like how to migrate
Yes.
to US as a surgical technologist. I think that would be a very good one as well. So thank you so much. Thank you, everyone. I want to use this medium to say thank you to all the members, the chairperson of the Education and Training, Anaesthetists from Rwanda, Wilson from Rwanda as well. They have other members, Blessing from Nigeria, Sachin from India, John Paul from Rwanda, and lots more. I don't want to miss anyone's name. There's many of them. So thank you so much for facilitating this. It's really been good. And by September 3rd, we have another topic coming up. That's optimizing professional career opportunities in the operating room practice, putting the patient first. So we're going to be having a professor from University of Benin Teaching Hospital, that is from Nigeria, is going to be taking that topic on the 3rd of September. So every 2 weeks, there is always a webinar across TORG platforms, and every chapter is represented. And thank you everyone for taking the time out of no time to even attend this session. If you still have questions, if you have suggestions, you can always leave it on your chapter group or send it to TORG info@operatingroomissues.org, and we can always get back to you. So thank you so much, everyone. Josephine, we know you are loaded. We definitely getting you back soon. And thank you so much. It's been a privilege.
Thank you.
To you.
No problem. I'm available.
Yeah. So thank
Have
you,
a good one,
everyone.
everybody. Or should I say good night?
Good night. Good night. Good night. Good night. Thank you, everyone. Bye. Bye. Bye.
Bye.
Bye. Bye. Bye.